Good morning, good evening, wherever you are. Welcome to another intensive care hotline and intensivecarehome.com live stream. Today's topic is about ICU wants to stop the ventilator and the feeding tube for my mum. They say she isn't waking up fast enough. And I want to dive right into this topic today and have other questions lined up that I want to answer from our readers and clients and followers, of course. Now, before we go into today's topic, just a little bit about me in case you may wonder what makes me qualified to talk about all topics intensive care. I am a critical care nurse by background. I have been working in intensive care / critical care for over 20 years in 3 different countries. I have also worked as a nurse unit manager for over 5 years. And I have been consulting and advocating for families in intensive care all over the world for the last 10 years. It's part of my intensivecarehotline.com. I'm also the founder and managing director of Intensive Care at Home, and you'll find more information at intensivecareathome.com. At Intensive Care at Home, we provide intensive care at home services for predominantly long-term ventilated adults and children, where we basically send ICU nurses and pediatric ICU nurses into the home for, again, predominantly long-term ventilated adults and children with tracheostomies that otherwise would be in intensive care long term. I also want to welcome our viewers that are watching this on replay. Unfortunately, you won't have the option to answer questions in real time, but please, I encourage you to type your questions below this video or send them to us to support at intensivecarehotline.com so we can get them answered, or make a video, or I can make a video about it, whatever the case may be. So feel free to keep asking questions so we know what you want to know and we can be responsive to it. Now, also some housekeeping issues for today's session. If you have any questions, please type them into the chat pad and I will answer them. If we have enough time, I will also open up the phone lines. Depends on how we go. But for now, let's just get started with today's question. And again, the question today is the ICU team wants to stop the ventilator and the supplemental feeding for my mother. They say she isn't waking up fast enough. Wow, what a dilemma here. And this question initially came from Bree. And Bree, what a dilemma you're in. I mean, literally what they're telling you is they want you to stop the ventilator and feeding because your mum isn't waking up fast enough. Well, I mean, what's fast enough? What is that? What does that even mean? The best example that I can give you there is, for anyone that has children, how long would you give your child to walk? How long would you stop if your child doesn't walk after 12, 13 months? Would you stop? Well, you certainly wouldn't. If it takes 15 months, it takes 15 months. If it takes 18 months, it takes 18 months. If it takes 2 years, it takes 2 years. So that, I do believe that the same applies here, that if ICU says, well, she isn't waking up fast enough, there are no timelines for this. What the timelines are in intensive care is often bed blocks, money, not having enough staff, and not waking up in a time frame that's convenient for intensive care teams, not waking up in time frames that is appropriate for the ICU financial budget, for their staffing levels, and staffing levels are currently very low in ICU, and that's all around the world. A lot of ICU doctors and ICU nurses have left ICU because of, they're simply burned out since the whole COVID thing. So, and stopping feeds is basically starving a patient. Now, that in my mind is negligent. It's not only negligent, it could also be perceived as euthanasia, and euthanasia is illegal, right? So, unfortunately, what we see across our client range is, or when we, interact with clients one-to-one, I would argue that at the moment we're getting one phone call a week where someone calls us up and says, hey, my mum, my dad, my spouse is in ICU. ICU is telling us tomorrow at 3 o'clock they're going to stop the ventilator and then my loved one will die. Now, this is absolutely shocking. I am absolutely outraged by what we are seeing on a weekly basis. It's basically ICU handing out death sentences to people and families feeling incredibly powerless with what they're being presented with. Unfortunately, we can turn these situations around, and we have turned. There's not a situation we haven't turned around. If we are presented with those situations, as long as people can follow advice, and that's probably the only prerequisite for us, that people can follow advice and work with us very closely. But that's almost besides the point. Who do ICUs think they are by ending people's life support? That's illegal in most cases. And it's another sign that ICUs and hospitals have lost all morals, all ethics to do the right thing for people. If patients or families have advanced care directives, and it's documented that they don't want treatment on a ventilator, they don't want treatment for inotropes, vasopressors, they don't want dialysis, they literally don't want to live, that's a different story. But very few, if anyone, has those directives. And in the absence of an advanced care directive, it's the family's prerogative to make those decisions. I can only encourage anyone watching this to have an advanced care directive, so that if, God forbid, you are ever in a situation where, someone needs to make decisions for you, that it's clearly documented what you want, But coming back to your mum situation there, Brie, they want you to stop the ventilator and feeding for your mum because they say she isn't waking up fast enough. Again, that's A, it's illegal, and B, it's probably against the law. You haven't shared your look. You are in Kansas, and it's not only illegal; it's against the law. But ICUs are very good at pretending that they operate in a vacuum and that they can do whatever they want. And the minute you challenge them, they backpedal pretty quickly. And bear in mind, we are not a legal. I'm not a lawyer. I'm just, everything that I'm saying is based on my experience, my extensive experience in intensive care, but also based on, real work that I've done or that we've done with clients all around the world in similar situations. And we can always turn these situations around by looking at the clinical stuff. If someone says to me, well, they want us to stop the ventilator and the feeds, well, my first question is, well, why? Give me the clinical facts. And then once we look at the clinical facts, then we can, argue on a clinical level. And we can also argue on a legal level, but, often the clinical is just enough. If, for example, if your mum is close to getting off the ventilator, then the question is, what else needs to happen before she can be safely taken off the ventilator so she can live, right? Sometimes feeding needs to be stopped because people can't digest feeds, but that's not the case here. It's simply a case of someone's not waking up, quote unquote, quick enough, we haven't got any timelines. You know, this Brie could be talking about 2 days, she could be talking about 2 weeks, she could be talking about 2 months. We don't know. She hasn't given us any time frames. But the bottom line is, you know, you got to question, and you got to question everything, you know. And once we have a good idea about what's really happening for a patient like this, again, it's very easy for us to turn this around. Bear in mind, approximately 90% of intensive care patients survive. Okay, given that 90% of intensive care patients survive, you know, the odds are in your loved one's favor, right? So why would your loved one be the one not surviving? Gotta ask that question, you know, especially since the odds are in your loved one's favor. Now, I am not talking about quality of life. I'm talking about someone surviving their critical illness in intensive care and leaving intensive care. It's hard to predict quality of life from that point onwards, but you know, you can then, once someone left intensive care, you know, alive, then I guess once that's happened, then you can look at quality of life issues. You know, the first step is always to survive, you know, this critical illness, and then move on from there. Now, you know, and even if your mum, for example, can't tolerate the feeds, you haven't given any indication for that, but I'm just, you know, trying to spin this in other directions here as well, so you can understand the full complexity that is intensive care. You know, let's just say your mum can't tolerate feeds, and that's one of the reasons they want to stop the feeds. Please bear in mind, there's always options such as TPN or IV nutrition, intravenous nutrition, total parenteral nutrition is the medical term. You know, so there's plenty of options for your mum to have nutrition one way or another. Other questions when someone isn't waking up that are imperative are, is your mum still on sedation? If they stopped sedation, how long has she been off sedation? If she's been off sedation for a few days and she's not waking up, has a neurological assessment taken place, i.e., has a CT brain of the scan been done? Has an MRI scan of the brain been done? Has an EEG been done? Has there been neurology input, right? Is your mum potentially in kidney or liver failure, i.e., if she's in liver failure, are sedatives not metabolized? Therefore, they're still in the body system, and therefore your mum is not waking up. Is your mum in kidney failure? If she's in kidney failure, again, are sedatives not excreted? You know, are they not excreted via the kidneys? Are they still in the system and she's not waking up because of that? If she's in kidney failure, does she need dialysis/hemofiltration? The same applies to opiates. Everything that I've said now applies to opiates. So someone in an induced coma often, you know, has sedatives such as propofol or midazolam/Versed, but also has opiates such as morphine, fentanyl, often in high doses, you know, and they keep people asleep as well. The other question here, Brie, is, does your mum have a brain injury? You know, God forbid, did she have a traumatic brain injury from a car accident or from any other accident? If that is the case, it would complicate things, but, you know, at least you can get to the bottom of why she's not waking up, you know. And quite literally, if she's not waking up fast enough for whatever reason and then stopping feeds, again, I argue that's euthanasia. Potentially worse, you know, could potentially be perceived as murder, and you know, and you got to ask about the rationale. Again, you got to look at what's really happening in intensive care currently, but also during other times. You know, no beds, no staff, no equipment, pressure from, you know, from emergency departments, from emergency rooms to admit more patients into ICU, and so forth. So I hope that illustrates what you should be doing here. I mean, the quickest way to turn this situation around is to talk to me directly, and then, you know, we can talk to the ICU there and really, you know, exercise your rights for this situation. Okay, let's move on to the next question, which comes from Natasha. Natasha writes, my 28-year-old husband had a major heart attack and now his brain has been majorly affected. He has been unconscious for 1 month and 2 weeks as of today, but he is opening his eyes, yawning, coughing and responding to the pain, but he is not fully awake. After the CT scan, the doctors commented that he has been affected by hypoxia majorly. The doctors are planning his discharge and asked us to find a physiotherapy rehabilitation center. Now we are in the process of finding them. Could you please respond to me? I'm extremely worried as we just got married 3 months ago. Right. That's a tricky situation, Natasha. I would imagine that if your husband had a major heart attack and he's now got a hypoxic brain injury, I would imagine that he had a cardiac arrest. He had probably had a heart attack that led to cardiac arrest with some quote unquote downtime. So what I mean by that is, probably had a cardiac arrest. He had potentially no oxygen to the brain for more than 3 minutes until the heart could be revived, which might have led to the hypoxic brain injury. So it's certainly a good sign that, after 6 weeks, 1 month and 2 weeks, he's opening his eyes, yawning, coughing, and responding to pain. But he's not fully awake yet. Again, similar to our previous example, what else is happening? As part of the hypoxic brain injury, is he having seizures? And same is applicable, to our previous example, Bree's example, does your mom have seizures? Is she on anti-seizure medications? And is she therefore being kept, because of the sedative effects of the anti-seizure medications, is she not waking up because of that? And the same might be applicable for your husband here, Natasha, that he may not wake up because A, he may still have sedatives and opiates lingering around in his body system. B, he might have had some seizures and he might be on anti-seizure medications to prevent seizures. And is that potentially stopping the ICU team from making a full neurological assessment? The other thing is, before he's going into rehab, other issues are such as, what's happened with the heart. Did he have treatment for the cardiac arrest? Did he have a heart attack because of, arterial occlusion, right? Has the heart been stented? Has he had an angioplasty? Has he had an angiogram? Does he need cardiac surgery, right? Another thing that you haven't mentioned yet is your husband being ventilated? Does he have a tracheostomy? To a degree, I argue yes, because it sounds to me like he's still in ICU. And I argue if he hasn't got a ventilator and a trach, he would be on a hospital floor. And you haven't talked about that. And they're asking you to find a physiotherapy rehabilitation center. Again, it also comes down to, is your husband ventilated? Does he have a tracheostomy or not? Because if he has a tracheostomy, the number of rehabilitation centers he can go to is probably limited, right? If he doesn't have a tracheostomy and he's not ventilated, your husband should go to any neuro rehab center, that should be focusing on his neurological recovery. Very important in a situation like that, Natasha, is get him mobilized, get him stimulated, right? There shouldn't be anything stopping them from mobilizing him, even if he has a tracheostomy or is ventilated, right? Next, if he is ventilated, God forbid, or has a tracheostomy, rehabilitation will be more difficult because a lot of time and effort will need to be spent on working towards weaning him off the ventilator, decannulating him, hopefully. But even for that, he needs to be more awake. I guess the good news here, Natasha, is your husband is 28. So, I do believe he has enough time to recover. And, even if your husband was 48, even if he was 68, I do believe the same approach needs to be taken to recover people, especially if that's what they want. And especially if they, have a supportive family around, and if they have talked about previously what they would want in a situation like that. I would think that your husband wants everything done. But a lot of it depends here on whether your husband is ventilated or not. A lot of it depends on, does he have any other comorbidities? What are they going to do to prevent another heart attack / cardiac arrest? What's the cardiologist saying? What's the neurologist saying is very important. And if he has ventilation / tracheostomy needs, he needs input from respiratory, of course. Another thing that you may consider, and this is only if your loved one, if your husband is a long-term wean, i.e. he can't get off the ventilator or can't get off the tracheostomy, you may consider home care with a service like intensivecareathome.com. So go to intensivecareathome.com if you're looking for home care specifically for ventilation and tracheostomy, or even if your husband only has a tracheostomy, even then home care might be an option. But, probably not before he has been properly rehabilitated, if that is an option, and I think it is an option. With Intensive Care at Home, we are currently operating all around Australia. You haven't shared your location, in all major capital cities and also regional and remote. You can contact us at intensivecareathome.com. We can also help you with the funding there if that's of concern. So I hope, Natasha, that helps in terms of what to do next. Do not give up. Your husband is only 28. Plenty of time to help him recover, and plenty of time to recover if the right steps are taken and the right treatment is being put in place. Okay, next question from Anne. Sorry, not Anna. Anne. Anne O. I'm not going to give away any surnames. It's Anne O. Anne surname starts with an O. And this is an intensive care at home question. What can you do for a patient that is on 24 hours on BiPAP? I believe it is no way to live. There's no quality of life. The patient is my dad. Oh, what a great question, Annie or Anna. Because I can actually give you a very good case study here. And I will make a complete video about this case study. But so this is a great question. Last year at Intensive Care at Home, we had a client in Melbourne, here in Australia, that had end-stage lung cancer, had a long-standing history of multiple cancers, and the cancer eventually spread into his lungs. And as he was slowly deteriorating, he was needing BiPAP 24 hours a day. Okay, so and clearly it was the gentleman's wish and his wife's wish to stay at home and not to be admitted to intensive care, because that would have been the alternative. Now, keep in mind, no palliative care facilities or palliative care wards can look after BiPAP, because that's an intensive care nursing skill. So we commenced 24-hour intensive care at home nursing services last year in September with this particular client. And then he passed away just a few days before Christmas in 2022. So, and again, that was his wish, to be kept alive on BiPAP for as long as possible. And then when the time came, he certainly didn't want to go back into ICU, certainly didn't want to go back into hospital. It was his wish to be to have palliative care and end of life care at home. So, and you know, we obviously work very closely with palliative care services as well to, you know, manage pain, to manage patient comfort, you know, making sure we've got all the right equipment at home, you know, working closely with home ventilator manufacturers, you know, such as ResMed or Philips, you know, making sure all the equipment is there, you know, liaising closely not only with palliative care but also with other doctors, again, managing patient comfort, managing patients' quality of life, you know, making sure all the equipment is there, such as hoists, such as a hospital bed, you know, oxygen concentrator, suction machine, you know, different masks for the BiPAP. Now, you are also saying, Anne, about, you know, patient comfort and, you know, that there's no way to live. A lot of it with BiPAP as well comes down what masks you're using, you know, and again, this is probably more specialized knowledge. You know, I remember in the early days in ICU, you had these big face masks, you know, that some of them were more comfortable than others, but some of them were very uncomfortable. And with this particular client, he had a nasal pad, he had a nasal BiPAP, you know, and that was fairly comfortable for him. And, you know, and the pain and the discomfort didn't come from the BiPAP. The pain and the discomfort came, you know, from his underlying disease, which was the cancer. So, but also to illustrate, you know, again, coming back to your question where you say, what can you do for a patient that is on 24 hours on BiPAP? I believe it is no way to live. There is no quality of life. The patient is my dad. Now, and again, we have other clients at home on BiPAP. You know, this palliative care situation that I just described is not unique to our service. We have other clients at home on BiPAP, you know, such as clients on cerebral palsy, even clients with dementia, you know. So there's a number of clients that we're looking after at home with BiPAP or on CPAP, you know, that otherwise would most likely end up in ICU. And the notion that there is no quality of life, it depends on the individual, you know, what they want. And, you know, if you take two options, one is having BiPAP in an ICU where it's noisy, where there's no quiet time, where, you know, it's noisy 24 hours a day. Patients have problems in getting into a natural day and night rhythm. Families, you know, live, quote unquote, live in intensive care, you know, and if you compare that with home care, I believe, you know, there is a big difference in terms of quality of life. So the notion that there is no quality of life at home, I strongly disagree with. There is no quality of life in an ICU. I agree with that, you know, but at home, the care is tailor-made for your dad, you know, and that makes all the difference. And it's tailor-made for you as a family as well. You know, it's not the hospital dictating what needs to be done at 10 o'clock in the morning or at 8 o'clock in the morning. At home, it's like, you tell us what you want and we make it happen. You know, it's a very different approach. Also, you know, again, a lot of it comes down to selecting the right mask for your dad as well. You know, comes down to that. And I don't know, it sounds to me like your email and also reads, you know, definitely reads some frustration. Maybe you're talking about not having quality of life. And maybe that also is hinting to your situation, because you might be spending day and night in ICU. And of course, you won't have any quality of life if you're doing that. You know, it's very draining for you as well, you know. And I'll give you another example. Currently, we are having an inquiry from a gentleman who's also end-stage lung cancer, and you know, he's now needing more and more oxygen, and we recommended for him to go on BiPAP as well, so that he doesn't need to go into ICU, that he can have some life-prolonging measures if that's what he wants, and then we can commence services at home, 24-hour intensive care at home as well. So, I think there are options for your dad, and I think the best way is for you to contact us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or just send us an email to info@intensivecareathome.com, and then we can walk the next steps with you. If you're in the US, you can contact us as well. We can now help you in the US as well with intensivecareathome.com. I will publish a podcast about that in the next couple of weeks, and I will, make an announcement there. Okay, so let's move on to the next question. And for anyone that's live on the show, if you have any questions, please type your questions into the chat pad, and I will get to it. So now next question comes from Nigel. Nigel says, does a coma patient know they died? I lost my dad in a coma. What was his last memory? Does he just remember being put to sleep? Does he have any idea that he is gone, or does he still think he's sleeping? Great question, Nigel. I really don't know. It's hard to, find the answer to this. I guess if your dad was awake while he was put to sleep, then I would think he may remember that. Does he have any idea that he's gone? I really don't know, Nigel. I guess when you look at ICU survivors, they say they don't remember much. Some ICU survivors say, well, I remember everything. I could hear people talking to me. I could hear my mum talking to me, my dad talking, whatever the case may be. What was his last memory? I don't know. I don't want to get metaphysical here, all woo-woo, but you're also talking about patients with real, with near-death experiences. Have a look what they report. Do some Google searches. They report some wonderful memories from near-death experiences, and they say, they saw the light. They were like in trance. Unfortunately, I don't have any answer to your question here. There's very mixed messages when people come out of a coma, what they report, whether they have any memory or whether they have all the memory or whether they have some memory like they were in the twilight zone. Some patients report that as well. They were being, quote unquote, in the twilight zone. Now, other people say that death is just the separation from body and soul. Again, I am not here to evaluate what death is or where people go after they die. I can't comment on that, but you may want to think about what approach you're taking here to find the answer to, obviously, to a question that is very important for you. Do you want to make sure your dad is fine? A lot of it will also depend on, they put him to sleep. What medications did they put him to sleep with? There are some very powerful medications where, I argue that people's consciousness is completely gone. A lot of it depends on the depth of the coma which they're induced in, and that depends on the strength of the medications they're getting. So this is more of almost like, I see this as a spiritual question, Nigel. This is not so much a medical question. Where's your dad now? Where is he? Is he in heaven? Is he somewhere else? I do believe in the notion that the death is the separation of body and the soul. I do believe into that notion. So, but I'm not here to, necessarily share my philosophy of death with you. I'm just giving you different ways, trying to find different ways to help you with this and find an answer, that gives you peace of mind, because I think that's what this is all about. It's about finding peace of mind where your dad is and so forth. Okay, now let's get to the next question. This question is from Phoebe. My husband is in a step-down ICU unit. After a sepsis diagnosis, he's not waking up and can't get out of bed or walk, which is a criteria for him to go into a rehab facility, and I am so worried. If he doesn't qualify, then I either will pay out of pocket for rehab or I will have to bring him home and care for him alone. What do I do now? Okay, let's read this question again. My husband is in a step-down ICU unit. After a sepsis diagnosis, he's not waking up and cannot get out of bed or walk, which is a criteria for him to go into a rehab facility, and I'm so worried. Okay, let's just stop there before so that I can answer the first part of the question. So he's in a step-down ICU. He must be stable enough to have left ICU. You know, ICU is often like ICU, step-down ICU. Sometimes it's also called HDU, or stands for high dependency unit. Sometimes it's labeled as progressive care unit now. But basically, once patients are sort of ready to leave, ICU, they can go to a step-down ICU or HDU before they can go to a hospital for a hospital ward. Now, he's not waking up. So the question is, again, like with our other examples, why is he not waking up? He's not waking up because he is still on sedatives. He's not waking up because he's potentially got a brain injury, or is he not waking up because he's simply weak after the sepsis? Find out why he's not waking up. Now, and then he cannot get out of bed or walk, which is a criteria for him to go into a rehab facility. I challenge that straight away. Again, you haven't shared your location, but a lot of patients, in ICU A need to get mobilized. Nothing's stopping ICU from mobilizing patients, assuming they're not hemodynamically unstable, assuming their blood pressure, their heart rate is stable, assuming they're not having any fractures that stop them from being mobilized, assuming they're not having any head injuries like a traumatic brain injury that stops them from being mobilized. So I argue the ICU is not doing what they're supposed to be doing to get your husband out of bed, getting him mobilized, getting him stronger, right? I believe the ICU is not doing what they're supposed to be doing, right? So how can he go into a rehab facility if they're not working him up for it, i.e. get him stronger there, right? So look, I did my nurse training in the 1990s, and I'm probably a very old-fashioned nurse in that aspect, but most ICUs that I worked in, we mobilized patients as soon as we could. And I believe that made all the difference. So for the ICU to say here, well, he's not getting any stronger, and if he's not getting any stronger, he can't go to rehab, that's a whole lot of nonsense. They're not doing the groundwork, and someone after a sepsis, is critically ill, and your husband simply might need time to recover. But it often helps if patients are getting stimulated, and mobilization and physiotherapy and physical therapy, that's part of stimulation, and it's part of working someone up and getting them ready for rehab. So nothing's stopping him from doing that, unless the ICU team there is complacent. And that's what it often comes down to. We see a lot of, when we talk to ICU, we see a lot of ICUs getting complacent and not doing the right things. And they're using too many excuses nowadays to say why they can't mobilize patients. Now, next, if he doesn't qualify for rehab, then I either will pay out of pocket for rehab or I will have to bring him home and care for him alone. What do I do now? Okay, so I argue, Phoebe, that if you haven't heard from the health insurance, you shouldn't worry about it. If the hospital is telling you that if he doesn't qualify, you will pay out of pocket for rehab, or I will have to bring him home. If you haven't heard from the health insurance directly, it's all gospel as far as I'm concerned. I'm hearing very often when we work with clients one-to-one that hospitals say, well, after so many days ICU, there will be no more payment for ICU. And I call nonsense on that, unless you are being approached by the health insurance directly. If you have not been approached by the health insurance directly, I wouldn't really worry about it. I'm sure they would contact you if that was of concern for them. Now, with home care, obviously you've heard me talk before about our intensive care at home service. Intensive care at home is also an option, however, not before all avenues have been exhausted to get your husband off the ventilator and the tracheostomy. Again, I am assuming that is the case here. You haven't mentioned it, but when patients stay in step-down ICU, and especially if they're not waking up, most likely your husband will have a tracheostomy or is having a tracheostomy. So, and going home on a ventilator with a tracheostomy is definitely possible. We've got numerous case studies at intensivecarehome.com. You'll find them on our blog. And that is actually much more cost effective than an ICU bed. An ICU bed costs $5,000 to $6,000 a day, and intensive care at home is half of that cost. But I don't think that is where your husband is at. Your husband needs to wake up. He needs to get physical therapy or physiotherapy. He needs to get out of bed. No more excuses. Again, the only thing that sometimes may stop people from being mobilized or getting mobilized is simply, they are hemodynamically unstable. That means if you mobilize them, their blood pressure drops or their blood pressure shoots up too high, their heart rate goes up too high or goes down too low. They have the risk of arrhythmias. Any of that could be a challenge. But you haven't mentioned any of that. I just think your husband needs to be slowly worked up for rehabilitation. And that can sometimes look as follows. It can look as like, you're sitting, your husband is being sat on the bed for 5 minutes today, right? He may tolerate that, great. If he doesn't tolerate it, get him back to bed. If he does tolerate it, maybe stop at 5 minutes. If you see he's getting exhausted, maybe then do 10 minutes the next day. Maybe it's 2 minutes today and 4 minutes tomorrow. You got to gradually build up, and you can already see it's a lot of work. It's a lot of work, but it can be done. And once he can sit on the edge of the bed, then the next day, put him to a chair, put him to a recliner chair, put him to a tilt table, to a tilt chair. There's many options in intensive care. If you question what I'm saying, type into Google ICU patient mobilization images, and you can see what images come up, and you can see that what I'm talking about makes sense, because there's plenty of options to mobilize patients, including them having a tracheostomy, including them being ventilated, sometimes even patients on a breathing tube, nothing stopping them from being mobilized. So, they've given you, Phoebe, the wrong narrative here. It's all about the right or the wrong narrative. They haven't given you the right narrative. They're trying to, wind down care for your husband, and that's just wrong. With home care, again, if you do want to focus on intensive care at home, once your husband has been mobilized a couple of times in ICU, we can mobilize him at home. That's not the issue. Other things are, what's happening with the ventilator? Can the step-down unit wean him off the ventilator, and then he can go on to rehab? So I think there's a lot of things you don't know yet in terms of what needs to happen. And, I keep saying over and over again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And once again, this is exactly what we're dealing with here. A lot of ground that need to be covered here. You know, and I can already sense that, you know, you are a bit panicky here, Phoebe, and maybe rightly so. I don't know the ins and outs, but from my experience, there's no need to panic here. It's just a matter of going through it step by step with your husband, you know, and getting him from that point A to point B without giving up, and doing it every day regularly. Very, very important. Okay, I hope that helps. And also with intensive care at home, again, you haven't shared your location, Phoebe. With intensive care at home, we are operating all around Australia, in all major capital cities. And if you're in the US, you should contact us as well. We are now having a clinical liaison nurse in the US that used to work for us here in Australia. Tara is her name, Tara Thorpe. And I will also be publishing a podcast with Tara in the next couple of weeks, so you can learn more about what we do in the US at the moment. And also, I will be publishing a podcast with Carly Dayton in the next couple of weeks, and we talk about mobilization in ICU in particular. Carly is an ICU nurse practitioner, and we'll be talking about mobilization and the importance of it in ICU in particular. Right, so Phoebe, take-home message here is mobilization every day. Weaning him off the ventilator, if that can't be achieved, then you can look at home care, but nothing stopping him from going to rehabilitation. What's stopping him at the moment is the ICU creating the wrong narrative, which is very sad. Okay, now here is another question from a reader. That was actually a comment on YouTube, and the lady says, "Hi Patrick, my husband has been on the ventilator for about 3 weeks and is still needing a lot of support with the oxygen. I sense the doctors are shutting us down. Is there hope?" Right. Now you have only shared your nickname, which says super cute Hello Kitty. Super cute Hello Kitty. Okay, that's your nickname there on YouTube. Again, I'll read that question out again. "Hi Patrick, my husband has been on the ventilator for about 3 weeks and still needing a lot of support with the oxygen. I sense the doctors are shutting us down. Is there hope?" Well, super cute Hello Kitty, there's always hope. Whilst I don't think that hope is a strategy as such, there's always hope. As long as there's life, there's hope. Again, you may recall that I said earlier, and also on many other videos, that 90% of intensive care patients survive. So why should your husband not survive? So that's question number one. The odds are in your husband's favor. Okay. Now, after 3 weeks, the ICU might get a little bit impatient. You haven't shared why your husband is on the ventilator, but after 3 weeks, the ICU might get a little bit impatient, and they might think, well, we better get this patient out because we're running out of time, we're running out of money, we need the bed, we're running out of staffing resources, whatever the case may be. But number one is, keep in mind, the odds are in your husband's favor. Number two, if he's on the ventilator for about 3 weeks now, does he have a tracheostomy? Okay. You know, if he's still on a breathing tube, I argue if he hasn't managed to get off the ventilator to this point, he needs a tracheostomy, probably urgently. Okay. Then, if he is having a tracheostomy, why would they shut you down? You know, why would they shut you down if he's still on the ventilator with a tracheostomy for about 3 weeks? So if he's still needing oxygen support, you know, again, that's what it comes down to, that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So if he's needing more oxygen support, that's great. But what else is going on? What ventilation settings is he on? What's the PEEP? What's the pressure support? What's the underlying ventilation mode? I.e., Is he already breathing spontaneously? Is he, triggering some of the breaths himself? What is his respiration rate, his breathing rate per minute? What do chest x-rays look like? Is the oxygen the only thing that's stopping him? For example, if he's on 50% of oxygen, but he's on a PEEP of 5 and a pressure support of 10, and he's already breathing spontaneously, what's going on? Does he have a pneumonia, right? Does he, for example, is he still sedated? Again, you haven't shared any of that. So you're barely giving me, 10% of the information that I need to know here to guide you, which, brings me back to the importance of sharing medical records with us so we can give you that crucial second opinion, so we can break it all down for you. Because ICUs can be very black and white, and it sounds to me like that this is what's happening here. The ICU seems to be very black and white. You're saying they're trying to shut you down, and I just go like, well, what else is happening? What information are you missing to stop the ICU from shutting you down? Because it often takes a second opinion and saying, well, are they doing this? Are they doing that? And then the situation can be turned around very easily. And you should be paying attention. If you're sensing the doctors are trying to shut you down, you're probably accurate in sensing that. But the question then is, what is it that you are missing? I.e., what questions have you not asked? What information are you missing? What do you need to learn about this situation that will help you to turn the needle and turn the situation around? And that's exactly what we can do here at intensivecarehotline.com. So I strongly encourage you to reach out to us here at intensivecarehotline.com so that we can help you turn this situation around. So I think I'll wrap this up for today. And I might actually do another one tomorrow, depending on how I go with time, because it is the Easter weekend and I might have a little bit more time than I normally do. If not, I will be back again next Sunday, 10:30 a.m. Sydney, Melbourne time, which is 7:30 p.m. on a Saturday night, Eastern Standard Time in the US, which is 4:30 p.m. Pacific time. And it is 1:30 a.m. on a Sunday UK time. Now, I appreciate you watching this, whether you were here live or whether you are watching this as a replay. If you have a loved one in intensive care and you need help, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, if you have a loved one in intensive care and you want to go home because your loved one is long-term ventilated, can't be weaned off the ventilator, or is a slow respiratory wean, ventilation, tracheostomy, but also on BiPAP, CPAP, and so forth, but also for complex seizure management or for any medical complexities that requires an ICU nurse at home, you should contact us as well at intensivecarehome.com. Again, call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecarehome.com. We're currently operating all around Australia, in all major capital cities and in rural and regional areas. And we're also now in the US. Please contact us there as well. Now, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day. And we answer all questions intensive care related via email and in the membership area. Now, if you need a medical record review, please contact us as well. We review medical records for patients in intensive care in real time, but also after intensive care, especially if you need closure, if you have unanswered questions, or if you're suspecting medical negligence. But we strongly encourage you to let us help you with reviewing medical records in real time, because it's critical that you get the second opinion in real time. As we've seen with all these examples today, with all the questions, you would strongly benefit from having a second pair of eyes from a professional looking at medical records in real time. So then a lot of your answers a lot of your questions will get answers automatically. Thank you so much for watching. Like the video, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, and comment below what you want to see next, or what comments and insights you have from this video. Thanks for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days. Take care for now.